We will follow a specific clinical pathway today. We begin with the pediatric trauma difference. Next, we cover the primary survey and ABC priorities. Then, we discuss stopping the vicious cycle. After that, we look at diagnostics and radiation limits. We will then examine specific mechanisms of pediatric injury. Finally, we conclude with damage control and management. This structure mirrors the exact chronological journey of a pediatric patient entering the trauma bay.
Let us begin with Section 1, the pediatric trauma difference. The foundational rule of pediatric medicine is that children are not just small adults. Their bodies handle physical stress in completely unique ways.
Blunt trauma is the leading cause of mortality in pediatric patients over 1 year old. But the way we measure the danger of that trauma is unique. In adults, an injury severity score, or ISS, of just over 15 predicts a significant risk of mortality. In children, there is a distinct shift. Children require an ISS greater than 25 to predict mortality. This shift happens because about 90% of children present with isolated injuries. These injuries are usually to the head or the extremities, rather than systemic trauma. The overall score might appear lower. However, the specific isolated injury remains incredibly dangerous.
Moving to Section 2, Primary Survey and ABC Priorities. When a child arrives, we rely on the Advanced Trauma Life Support Framework. We must secure their immediate survival before we diagnose anything else. The first priority is catastrophic bleeding. This requires immediate direct pressure. Next, we evaluate the airway and the cervical spine. Infants require a neutral neck position. Older children need a slightly extended position. This is often called sniffing the morning air. Be very careful. Overextension will mechanically obstruct a child's airway. Next is breathing. Hypoxia drives pediatric cardiac arrest. You must always provide high-flow oxygen via a non-rebreather mask. Remember that a child's rib cage is highly flexible. The ribs can bend inward upon impact. This can cause severe lung bruising without any broken bones. Watch closely for a tension pneumothorax. If trapped air collapses the lung, perform immediate needle decompression. Do not wait for an X-ray.
You must also be highly vigilant for SCIWRA. This stands for spinal cord injury without radiological abnormality. Children have proportionately heavy heads. They also have highly elastic neck ligaments. During trauma, the spine stretches dramatically. This stretch can severely damage the spinal cord, but because the bones are elastic, they snap back into normal alignment. Standard X-rays will look completely normal. If there is high-energy trauma or any neurological symptoms, an MRI is strictly required to see the damage.
We continue with circulation, disability, and exposure. For circulation, intravenous access is essential. If an IV fails, immediately move to intraosseous access. This places a line directly into the bone marrow. The ideal spot is the upper shin bone or the shoulder bone. Administer 10 milliliters per kilogram of warmed isotonic fluid. For disability, use an age-modified Glasgow Coma Scale. Always monitor for low blood sugar. Children cannot release stored sugars easily. Their levels can drop dangerously fast under stress. For exposure, keep in mind that children lose heat rapidly. They have a high surface area to volume ratio. You must prevent hypothermia immediately by removing wet clothes and applying warming blankets. This is essential to prevent blood clotting failure.
The crucial metric to remember here is 20%. In children, low blood pressure is a very late sign of shock. A child's cardiovascular system compensates incredibly well. Their blood pressure will stay perfectly normal until they have lost roughly 20% of their total blood volume. By the time that blood pressure actually drops, they are on the edge of complete cardiovascular collapse. You must act on early signs. Look for a rapid heart rate and poor skin color long before the blood pressure falls. This brings us to Section 3, Stopping the Vicious Cycle. If the primary survey is not handled perfectly, the patient enters a dangerous physiological cascade. This cascade is known as the lethal triad.
It consists of acidosis, hypothermia, and coagulopathy. Poor blood flow directly causes high blood acidity, or acidosis. Acidosis ruins the blood's ability to clot. It increases proteins that stop clot formation and speeds up the breakdown of existing clots. Next is hypothermia. For every 1 degree Celsius drop in body temperature, there is a 10% drop in clotting ability. If the child's temperature falls below 34 degrees, platelets pool uselessly in the spleen. You also need to monitor calcium. Preservatives in stored donor blood bind to the patient's calcium. Without enough free calcium, platelets simply cannot function.
To stop this lethal cycle, we use highly targeted therapy. The ideal approach uses point-of-care blood testing to replace specific missing factors. If that is unavailable, we use ratio-based transfusions. These doses are based strictly on the child's weight. Packed red cells are dosed at 20 milliliters per kilogram. Fresh frozen plasma is also 20 milliliters per kilogram. Platelets are given at 10 milliliters per kilogram. Cryoprecipitate is 5 milliliters per kilogram. If major bleeding started less than 3 hours ago, administer tranexamic acid, or TXA. You give a 15 milligram per kilogram bolus. This is followed by a 15 milligram infusion over 8 hours.
We now move to Section 4, Diagnostics and Radiation Limits. Once the child is stabilized, we conduct the secondary survey to find all injuries. However, imaging in children carries severe risks.
Children are highly sensitive to ionizing radiation. We must limit it strictly. A chest X-ray is mandatory. A neck X-ray is only done if the mechanism of injury suggests it. For a head CT, timing is critical. It must be done in under 1 hour for a coma score under 14. Triggers for a head scan include a bulging soft spot in infants, abnormal pupils, or any loss of consciousness. For the abdomen and chest, use a specialized single-volume dual-contrast CT scan to limit radiation. Never scan blindly. Only scan based on strict triggers. These include visible stomach bruising, severe abdominal pain, or elevated liver enzymes.
In adult trauma, a fast ultrasound scan is standard practice. But in pediatric trauma, fast scans are notoriously difficult to interpret. A child's internal anatomy is highly compact. Small, completely normal amounts of bodily fluid can look exactly like internal bleeding on an ultrasound. Because of this, fast scans are generally not helpful in pediatric trauma. You must rely on thorough physical exams and strict CT scan triggers instead.
Section 5. Mechanisms of Pediatric Injury. The exact way a child gets hurt dictates the hidden internal damage you must look for.
There are 3 classic mechanisms. The first is the lap belt injury. This causes forced forward bending. The bowel and bladder are crushed against the rigid spine. Warning signs of bowel injury here can be delayed for up to 72 hours. The second is the handlebar injury. Falling onto a bicycle handlebar crushes the upper organs. This severely damages the pancreas and intestines. The third is the straddle injury. This causes trauma to the groin. The absolute rule here is to look for blood at the urinary opening. If you see blood, never insert a standard urethral catheter. You must use a catheter placed directly through the lower abdomen. This avoids destroying a torn urethra.
You must carefully evaluate bruising patterns. We have to distinguish between accidental trauma and suspicious, non-accidental injury. Accidental bruising typically occurs on prominent bony areas. Think of the forehead or the knees of a very active child. Suspicious bruising happens in protected soft tissue areas. This includes the cheeks, the neck, the genitals, and the back. If there is a mismatch between the reported time of injury and the color of the bruise, that is a major warning sign. Always remember to rule out medical mimics first. These include benign birthmarks or systemic blood clotting disorders.
Finally, Section 6, Damage Control and Management. This details what happens when definitive care is required.
The overarching rule is that non-operative care is the standard for hemodynamically stable children. In the abdomen, the spleen and liver account for 70% of blunt injuries. If the child is stable, we manage these solid organ injuries with strict bed rest. We do not operate. However, if a scan shows free air in the abdominal cavity, this means the bowel is perforated. That is an absolute indication for immediate surgery. For orthopedic injuries, children heal remarkably well without surgery. But if a fracture is angled and involves unfused growth plates, it requires immediate referral to a specialized pediatric orthopedic surgeon. This prevents stunted growth.
If the child is unstable, the non-operative rules no longer apply, but we do not attempt a perfect, complete surgery right away. This brings us to the concept of damage control surgery. The primary goal of damage control is to delay the final anatomical repair. Instead, the immediate priority is to correct the physiological derangement. We must fix the acidosis, reverse the hypothermia, and restore blood clotting before the body can survive a long operation.
Damage control surgery is executed in 3 distinct steps. Step 1 takes place in the operating room. The surgeon makes a rapid midline incision. They pack all 4 quadrants of the abdomen with sponges. This pressure tamponades the bleeding. The surgeon controls contamination but stops there. Step 2 moves the patient to the intensive care unit. The abdomen is temporarily left open. The critical care team works continuously to restore perfusion, warm the patient, and stabilize organ function. Step 3 is the return to the operating room. Only when the child is physiologically stable do they return. The surgeon then performs the final anatomical repair and safely closes the abdomen.
Let us summarize this clinical pathway. For the airway, ensure careful positioning and maintain a high suspicion for hidden spinal injuries. For breathing, strictly avoid hypoxia and watch for lung contusions under that flexible rib cage. For circulation, remember that a drop in blood pressure is a very late sign of massive volume loss. For the environment, you must actively stop the lethal cycle of hypothermia and clotting failure. For diagnosis, strictly limit radiation exposure. Finally, for management, default to non-operative care if the child is stable and rapid damage control surgery if they are unstable.